Hi everyone, it's Bridie Roach from Brisbane. As you can see, I'm speaking on Forefoot, but I'll begin by a little scenario. So imagine you've just attended a foot lecture at the ASA conference and it's now Monday morning, you're fronting up to work, ready for a coffee, and you find out the first patient of the day is a paediatric foot who has pain and a limp. Great, you think. Young feet, 8 AM, can't be too offensive. Maybe I'll practice something new. Maybe I'll look for something really obscure that will impress the radiologist today. So you dive in and you look for the most obscure pathology that can cause a young patient to limp. You start on the dorsal foot and you compare the navicular bones, hoping to find Kohler's disease. So that's an osteochondrosis that can cause young patients to have these small, underdeveloped, mal-shaped navicular bones. But sadly, your case, not that exciting. To speed things up, you ask the young patient, put your finger right on the pain. So they point to the lateral side of the foot. You notice a prominence and a redness over the styloid of the fifth metatarsal base, and your longitudinal image looks like this. So you see some increased vascularity with sensitive Doppler settings. You see a little peel of bone. So you take a few more pictures, and at this point you might just say, look, I'm just leaving the room, check that we've got all the images we need, and you head out and you go and Google it. And Radiopedia tells you there's a whole raft of pathology, at least 4 things shown here, which can all cause pain with a bony fragment at the fifth metatarsal base. So to help you wade through the differentials, you're going to need some clinical questioning that's quite targeted. So you go back in and you ask some targeted questions and you discover, no, there's been no trauma, no inversion, sprain injury. The pain's been there for weeks, low grade, and it flares up after running and kicking at soccer training. So given that the patient's 13 and skeletally immature, what do you make of this bony fragment? So as it turns out, this is a completely normal secondary ossification centre called an apophysis, and it goes on to form the tuberosity of the fifth metatarsal. So essentially it's a growth plate. It appears somewhere between age 8 to 14, but usually around age 10 for females, age 12 for males, and within 1 to 4 years after its appearance, it'll fuse and it forms the tuberosity of the fifth metatarsal. So when it's painful and looks different, we call it apophysitis, and it's usually caused by traction, repetitive traction. So in this location we call it Iselin's disease, or Iselin's disease as I'll be pronouncing it today. So our non-tender side is the bottom right. Our tender side, you can see slightly thickened soft tissue and a little bit of fragmentation. And then your second patient of the day is 11 years old, also complaining of pain at the lateral foot. So you take some comparison images, you're all over this now. You look at Doppler and you notice the same sort of thing. So the X-ray is quite normal but does show a tiny fleck of bone. So the hyperemia is what's leading you to make, at this stage, the diagnosis of Iselin's disease. With this particular young man, he had pain that was brought on or got worse with, again, soccer. So the proposed cause for Iselin's disease is repetitive traction or microtrauma on a growth plate. So it's much like the condition called Osgood-Schlatters in the knee, if you're familiar with that. So I'll briefly talk technique. So to look for this condition, start by identifying your peroneus brevis and then find its insertion, and then slide slightly towards the plantar aspect if you haven't found the apophysis. The early signs that you're looking for in Iselin's disease are hyperemia around one apophysis and not the other, and some soft tissue edema, and like the MR, showing very subtle periosteal inflammation and soft tissue edema. This is what we may see on ultrasound. As this disease is just more like a chronic stress syndrome, if you diagnose it early, the treatment's really simple and it is just to offload the joint. Podiatrists may use a orthotic. They employ lots of stretching to tight muscle groups, and obviously the young person rests from their sport and uses ice and analgesics. In rare cases, you may need a boot for a couple of weeks. So these are the soft tissue changes of early apophysitis that you can see here is the abnormal side, here's the normal side. But if we don't diagnose it early enough, the implication is that it can progress to avascular necrosis. And at that stage, we start to see more fragmentation of the apophysis, and the X-ray may then become a bit more useful. And potentially, some of these growth plates don't fuse because of the constant traction and the lack of rest. So of note here, the apophysis is parallel with the shaft of the metatarsal. So the orientation of that bony cartilage gap there is important. So if we go back to our radiopedia differentials now, most acute fractures produce a cleft which dissects more perpendicular to the orientation of the metatarsal shaft. So in our first X-ray, we're seeing a Jones fracture. The second X-ray, we're seeing an avulsion. The third, we're seeing an avulsion plus an apophysis. And in the fourth, we're seeing a rare os, which may result from malfusion of the apophysis, and it's called an os Vesalianum, and it's usually identified within the peroneus brevis tendon, and that helps distinguish it from an os perineum, which is a bit more proximal and found in peroneus longus. So just note the location of these various acute fractures, and that can help distinguish between these that are presented here. So what else inserts on the styloid of the fifth metatarsal? So obviously there's peroneus brevis, but there's also the lateral cord of the plantar fascia. So just around the corner in transverse, you'll see another tendinous looking structure, but it's a fascia. So note different probe orientations for these two structures. Dorsal approach for peroneus brevis, a more plantar lateral approach for the lateral cord. So obviously what else can be misdiagnosed as Iselin's disease is a fasciopathy of this lateral cord of the plantar fascia. It's a rare condition, but definitely something we see in our younger mobile population. So you can see there's irregularity of the bony enthesis. It's thickened, we've got some calcification forming and some increased vascularity. Now to some forefoot pathology. So imagine your ultrasound workday has gone swimmingly. You've been on time all day. Your long lunch break meant you could go to the gym. And now the final patient of the day is another foot. So you grab out the referral, you start reading it. It says pain under the second metatarsal. Excellent, I'll start there. And then it starts with an essay saying, oh, there's pain here and pain here and pain here. And you sort of become a little deflated thinking how late you're going to finish. But you diligently go in and your first image is brilliant. You think, yes, I found it. There's fluid in the fat pad. It's under the second metatarsal. That's it. But then you think, well, hang on. The patient's young. They're really committed to their sport and they're asking, when can I go back to sport? So you think, okay, maybe I'll look a little further. So I'm presenting to you 3 abnormal adventitious bursa, and they're all in the submetatarsal fat pad, and they all have different pathogenesis. I'll return to these cases again, but right now I'm going to discuss 4 more pathologies. 3 are common and 1's more exotic, and we'll start with that. And for each pathology we'll discuss the appearance, why it occurs, where it's located, brief technique, along with a wall of shame example, and we'll discuss implications for underdiagnosis. So first to Freiberg disease or Freiberg infraction. It's a rare and progressive type of osteochondrosis. It affects the epiphysis of the second metatarsal head, and it predominantly occurs in our young adolescent athletic female population. The appearance early is the high signal or the stress reaction in the bone, so we see bone marrow edema here. And in terms of pathogenesis, one of the predisposing factors implicated in Freiberg is a plantar plate tear, and we can see that in this same patient as the previous slide. There's the high signal in the subchondral region. Here's the high signal in the plantar plate indicating a gap. But so too a long second toe. Things like genetic and hormonal changes may be a causal factor, and then there's repetitive microtrauma. And the microtrauma is proposed to damage the small nutrient arteries in this region that then feed the subchondral bone. So an early sign to look for an ultrasound, even though this is an MRI, is this soft tissue swelling, dorsal joint effusion, and tenosynovitis as seen here. Stress fraction may be something we can detect as well. So back to our tale of 3 fat pads. So this first adventitious bursa was someone who suffered from Freiberg disease, the patient we were just looking at. So the most characteristic appearance in Freiberg is a central depression in the second metatarsal head. You can see also the flattening of the metatarsal head in this sagittal view and the high signal on the nuclear medicine. Note also, apart from highland dancing, this lady also suffered a hallux valgus deformity, which is probably what predisposed her to Freiberg. So what are the implications if we underdiagnose Freiberg? So if we can detect it early, the conservative treatment can stop the ongoing osteonecrosis of the joint. So the ischemic epiphysis eventually means that we have a widened joint space, and that alters the biomechanics. You can see here the more severe scalloping in the epiphysis there. And I want you to note the lack of Doppler activity in this top right widened joint. So due to misdiagnosis, we can see that this patient has now total loss of her joint space. So necrotic tissue was replaced by osteophytes. And the MR shows the concave epiphysis along with subchondral bony cysts. And on ultrasound, we can see that osteophyte. So it's likely that restorative surgery employed a little earlier could have prevented her progressing to this grade 5 disease. And now she's suffering pain chronically. Even 6 years later, this is her ultrasound. She's now got another stress fracture of the second metatarsal shaft. We see increased Doppler signal adjacent to this periosteum, which is the little hypoechoic layer. And they're typical signs of a grade 1 stress fracture. So here's a little tip on how not to join the wall of shame. Just ensure that your technique looks dorsally and plantar at the MTP in question, and we won't miss markers of Freiberg disease. When you're looking for stress fraction, make sure your Doppler settings are about 3 to 5 centimeters per second, so you want a nice low scale. And then don't overgain your color Doppler. We don't want to see flow in the subcutaneous fat, even on the normal side. And make sure you know what the differentials look like. So the differentials for Freiberg disease are things that make the joint look abnormal and degenerative. So things like gout, rheumatoid arthritis, and osteoarthritis. And I haven't got time to go into them in detail, but just remember, Freiberg is not a condition of the great toe, whereas gout usually is. Freiberg will not show erosions like this, which are typical of gout and sometimes rheumatoid. Freiberg won't show pannus, and it doesn't usually result in a dorsal effusion that has these little white flecks in it, or the snowstorm appearance of gout. Osteoarthritis normally narrows a joint, whereas Freiberg widens it, and the osteophytes, I'm sure you've seen something like this over the dorsal midfoot. And it's more common, osteoarthritis more common in the first MTP again. Spondyloarthritis or your systemic degenerative joint diseases tend to light up like Christmas trees. So simple questions of your patient: do you have a systemic autoimmune disease? Have you had blood tests for inflammatory markers? They all help you to narrow the diagnosis. And we're not the be all and end all, so if you find any findings around the second MTP, try and push to have the patient go to MRI for definitive diagnosis to exclude Freiberg, because ideally we treat it early and we avoid the surgery. And if you want to have a look at the surgery, there's plenty in the literature about how they reconstruct the joint. So a favourable outcome from you sending that patient off to MRI is that the report simply says isolated stress fracture. So in this 20-year-old female athlete who ran a lot on hard surfaces, we can see periosteal changes, we can see echogenicity or increased echogenicity of the overlying soft tissue, we can see soft tissue edema, tenosynovitis, and she was then sent for an MRI to exclude Freiberg, and she didn't have Freiberg, so that's excellent. But what we do see is a grade 2 stress fracture, meaning there's now high signal within the bone shaft, in addition to this periostitis that was confirmed in the axial view. So commonly a stress fracture and Freiberg disease occur in the same way, so through repetitive load bearing, but their locations are different. So ideally, again, you pick up a stress fracture early. There's a grading system for it. We want to see it before the bone remodels. So in this case, you can see there's more thickening of the periosteal layer and now a cortical change. So there's on the ultrasound, a bony lump, and that corresponds with this callus that we're seeing now on X-ray. So that makes this a grade 3 stress fracture. Now in terms of technique, when you're looking at the metatarsal shafts, I tend to use a 12.5 frequency probe. I found that sometimes the higher frequency probes can miss the Doppler activity, so that's just a little tip to play around with the sensitivities of your machine. Now our second last topic of the session is plantar plate tears or pathology. The plantar plates I'll discuss are digits 2 to 4 because their anatomy is all the same. The great toe is outside the scope of this presentation because the anatomy is very complex. So our plantar plates extend from your metatarsal neck to the proximal phalanx. Obviously they're on the plantar side. I want you to note that the flexor tendon overlies the plantar plate and the plantar plate is not thicker than the tendon. So what we see beneath the plantar plate is hyaline cartilage, which is the green arrows. And obviously the plantar plate being fibrocartilage acts to stabilize the joint in the dorsal plantar direction to stop the subluxation of the prox phalanx up this way when you're weight bearing and in the push-off phase of walking. And it forms the capsule of the joint, so it contains synovial fluid. Now from my little drawing here, I just want you to note that bands of the plantar fascia also insert into it along with this collateral ligament of each MTP. So what can go wrong? So again, due to mechanical loading, the plantar plate can tear and it can also become degenerative. So the common location of any pathology of the plantar plate is the second MTP and then after that the third, and it's mostly towards the lateral aspect of the second, and that can be because the second toe is longer and bears the most weight. So defects in the plantar plate can occur post-traumatically, so stub toe, or they can be acquired through degenerative change, and at times they're not symptomatic at all. I've put this in because it's a typical example of the location, so it's the second MTP, it's the lateral aspect of the plantar plate that we're seeing a tear in, and we're showing you here what's important to measure. So in the transverse plane we can see that it's a full thickness tear top to bottom, but only partial width and less than 50%. And in the longitudinal we can see the length has been measured. We can see exposed cartilage, so we're seeing greater reflection from the hyaline cartilage, which helps confirm that there is a defect. The longitudinal image is labelled lateral, so we know the location and we know that it's at the distal insertion onto the proximal phalanx. And that's the really typical location. Now note that in the lateral image here, we're not seeing tendon, and that's because the probe's been moved away from the midline and angled in from the side, and that would make a good image. So the scan technique in longitudinal, you use a 17.5 megahertz probe. You scan dynamically by dorsiflexing the joint, and you also rock onto the distal end of the probe footprint, so we're approaching that MTP almost end on, and we ensure that the plantar plate is brought parallel with the top of the screen. Then to the transverse assessment, you start by finding the proximal phalanx, which has a little scooped surface, as opposed to the metatarsal, which looks more like a rainbow, it's convex. And for quality imaging, you tilt the probe so that you get the most reflection from the plantar plate. So you scan back and forth from proximal to distal. So here's one for the wall of shame. It's an ultrasound contribution. If the plantar plate is not parallel with the top of the screen, then an isotropy can mimic a tear. So this poor quality longitudinal image doesn't show us the most critical portion of the plantar plate towards its insertion. It's not visible. Same here, we get good reflection here over the metatarsal head, but our business end is not well visualized. So obviously the probe wasn't rocked onto its distal end, and perhaps this sonographer had someone belting down the door with a full bladder and they were just keen to get out the door. So apart from a tear, we can look for capsular hypertrophy and fibrosis. So again, the hotspot is the lateral second MTP. Often the referral from a podiatrist will say query capsulitis, which is more of a reference to the pain the patient feels, or the patient will feel like they're walking on a little painful pee. So our transverse image is to show uniform echogenicity and thickness. So you can notice here that there's thickening of only the lateral side of our second plantar plate, whereas we've got a uniform thickness on the third. You can also note the tendon is slightly partially subluxed to one side, so possibly there was a slight toe deviation. And there's nearly always in this setting of thickened capsule a coexisting plantar plate tear. And in this case there was, as seen in the cine loop on the right. You can see a little defect running through the thickened plantar plate. I've inserted this image from a different patient just as an example of pericapsular inflammation, as seen in this positive Doppler signal we're getting just beyond the plantar plate insertion. And there's also fluid in the submetatarsal fat pad, which is commonly seen with plantar plate tears. We can also see some calcific change within the thickened capsule. So why this lady suffered this condition was her commendable commitment to high heels in the workplace every day. She's convinced she has to wear it to impress her clients. And now I'll just head back to our previous patient because I want to mention what's important to document with tears. So the medial side of the second MTP, the plantar plate thickness here shows us how thick the lateral side should be. There's a partial defect laterally with coexisting capsular hypertrophy. So you can see the little partial defect. And importantly, we can see the defect not only in longitudinal but in transverse, as seen here. So you need to note whether it's lateral or medial or central. You need to note whether it's less than or more than 50% of the transverse width and whether it's complete. And also, does it have a longitudinal interstitial component? So both grade 1 and 2 can have plus or minus a longitudinal intrasubstance component. Grade 1 is less than 50% width, grade 2 is more than 50% width. So in this case we're looking at a grade 1 tear. So the same patient continued. Because there is complete top to bottom disruption in this plantar plate, it's actually led to a joint fluid leak into that submetatarsal bursa. So we've solved now the mystery of fat pad number 2, which is this one. So thank goodness you didn't just take one picture and leave it at that. The presence of a dorsal effusion is also really common with plantar plate tears, so that's something else to look for. So this time our wall of shame image is brought to us by MRI. This is an axial T1 weighted MR image where you can see this sort of bulge coming from the web space. So these inflammatory changes to the plantar plate and soft tissues can extend into the intermetatarsal space and mimic a Morton's neuroma, and we call it a pseudo-neuroma sign. So in this case, the MR was called Morton Neuroma, and at that point some surgeons may have jumped in and referred her for a radiofrequency ablation of the nerve, and this would have been the wrong treatment for this particular patient. So immediately before the procedure, the sonographer obtained this image, which is from the lateral aspect of the second plantar plate, and you can see it's grossly thickened. And so the treatment plan was changed. We're no longer looking at Morton neuroma, we're looking at pericapsular hypertrophy. So the take home with plantar plates is that there can be more than meets the eye. A grade 3 or 4 tear may involve disruption to the collateral ligaments, and that's something that we need MRI's help for. So here's the plantar plate tear we may have seen on ultrasound, but what we didn't see was the defect through the collateral ligament. So without early conservative management for the grade 1 to plantar plate tears, we get insufficient stabilization for the MTP joint and the associated structures, and it can ultimately result in a really painful deformed digit. So sometimes the toe begins to deviate and we suffer from a hammer toe deformity, which is seen bottom right, and then the tip of the toe loses the ability to grip onto the floor. So we can see this is a podoscopic view that the toes don't ground touch. And perhaps an earlier surgical reattachment could have prevented something like this end-stage deformity, which is crossover toe, and definitely a grade 3 tear, which would involve collateral ligaments. So I don't want you to get too excited about non-symptomatic tears. Some are through acquired degeneratively and don't cause pain. You'll see a lot in elderly patients. So this is a very chronic defect, and you can see that the plantar plate itself is quite thin and attenuated, and it's just an elderly patient with a tiny little degenerative change. So for a change of pace, we've talked about how plantar plate tears can lead to fluid in the submetatarsal fat pad, but in this case we're just seeing adventitious bursitis. So it implies that there's fluid in a region of high pressure where there's no typical bursa, so there's no mesothelial cells lining the bursa. So the fluid tends to be quite ill-defined, and it's commonly found in places like under the big toe or over the lateral foot or the perineal tubercle. And ultrasound's role is firstly to exclude foreign body and infection, and obviously to image the plantar plate and look at all those things we've been talking about. But in this case, the MRI just proved there was absolutely no coexisting pathology. So to talk about something that can be difficult for sonographers is distinguishing adventitious bursitis from these guys here, which are rheumatoid nodules in patients with proven rheumatoid arthritis. So rheumatoid nodules can also occur in high pressure areas, but as you'll note, they're more well circumscribed. So again, ask clinical questions. So we've solved now the third case of fat pad fluid, and our adventitious bursitis was responsible for this image here. So the take home for fluid in the submetatarsal bursa: assume that the fluid has drained south from somewhere else. It's the furthest south point in the body. So routinely look for intermetatarsal bursitis, which we're going to talk about next. Look for plantar plate tears to see if the fluid's leaked out of the MTP joint. So a quick review of your web space anatomy. The intermetatarsal bursa lies between the metatarsal heads. It's within a region of fat where it can become compressed between metatarsal heads, particularly if it's a narrow space to begin with. The interdigital nerve then runs beneath a ligament called the intermetatarsal ligament, and it runs with a little neurovascular bundle. So after this area, after the ligament and beyond the metatarsal heads, the nerve then splits into two branches, and each branch flanks the adjacent toe. And the obvious implication for our technique when looking at the nerve is that it's closer to the plantar aspect of the foot. So you can see it here from image from beneath. We can see a tiny little nerve within fat. Here's the common plantar nerve, so we can call this the interdigital nerve, and this is where Morton Neuroma occur. So we image the nerve in longitudinal with a 12-5 probe. The normal appearance of the nerve will be 1 to 2 millimeters in thickness and be quite uniform. It's also going to dive slightly deep away from your transducer the more distal you image, and that's because it's draped over the the intermetatarsal ligament at this point. Often this ligament creates a shadow along with the metatarsal head, so that shadow's very normal, it's not a bursa. And when we're asked to look for Morton's neuroma, we're essentially looking for fusiform enlargement of the nerve, like this image. So you can see there's normal nerve thickness trailing off either end of this fusiform enlargement, and the bursa has been outlined for you. It's towards the dorsal aspect. So what makes a good image and a bad image? So in a good image, your finger is pushed on the dorsal side into the web space at the level just beyond the metatarsal head and beyond the transverse view of your intermetatarsal ligament. So the indent makes the nerve flatter, pushes it towards the probe, and helps define the epineurium, which is this echogenic outer margin. It's rare to have neuropathy without bursitis, and the more chronic the bursitis, the harder it is to compress the nerve just with dorsal pressure, and we don't want to include the bursa in our measurement. So what other technique can you employ when you can't compress the bursa? And what's the implication for over measuring the nerve anyway? So ultrasound contributes to the wall of shame here. This was measured as the nerve from here to here, when in actual fact the nerve is only this most plantar component. The implication is that if you measure a nerve over 5 millimeters, then surgical treatment may be considered, and it's usually a dorsal approach to cut it out. But with a better technique on this same patient, the epineurium is defined and we can see that it's actually not over 5 millimeters. So you only want to include the portion that has a fibrillary pattern, because that's the nerve fascicles. So treatment when it's under 5 mil may be 2 attempts of HCLA to settle the inflammation, and afterward maybe a radiofrequency ablation of the nerve. So let's talk about why this image is so much better than the one on the left. And that's because a Mulder maneuver has been performed. So sliding from the MTP into the web space, you can see dorsal compression. There's the skin surface is squashing the bursa. But now this is the Mulder maneuver. So you're applying lateral pressure on the 1st and 5th toes to squeeze that web space tight, and now the nerve is popping up towards the plantar aspect. So now we can define the epineurium and measure the nerve. Now Mulders won't always work when there's no bursitis. It works better on an abnormal web space when you're seeing a shadow that you can't compress. Now to a more obvious case. So we can see a Mulder maneuver being performed. There's distortion of the bursa, and what's popping up is the solid component of the nerve. So you can actually feel a click in this patient. Now the click is not necessarily indicative of a neuroma. It can be that chronic bursitis that clicks as well. But once the Mulder's been performed, we can now measure the nerve more accurately. Now to a wall of shame image. This is a non-example. We don't want images like this. So you can see here would be the region of the intermetatarsal ligament. Here's the dorsal skin, and it's not compressed very far. It should be compressed more proximally in the foot near the metatarsal head. There's the shadow from the intermetatarsal ligament. So here would be the location of the nerve and the neuroma. We don't tend to get neuromas distal to the metatarsal head. The web space is at its widest in this region, which is between more the proximal phalanx, and we just don't suffer compressive effects at that level. So there's a few things wrong with that image, and it's likely that this is just normal fat that's not being compressed sufficiently. Another wall of shame. So this is an MRI, an axial view where there's a teardrop shaped pseudo lesion coming from the web space, and it was thought to be a possible Morton neuroma. However, with ultrasound and using the Mulder's technique to compress this shadow, we can see the bursa was the culprit, not the nerve. So the nerve is completely normal once the Mulder maneuver has been performed. So you may be asking, why not do the scan in transverse, since that's how MRI does it? So the reverse teardrop shape on ultrasound looks like this. And sure, you know, it can be a helpful tool, but the downfall is that the probe is either too distal or too proximal and looks completely normal, and you miss the neuroma. This displacing tissue as well may include things like fat and synovial fluid as well as the nerve, so there's more likelihood of a false positive for a neuroma. The dorsal approach, does it work? Well, sometimes it's really helpful, and certainly how we perform injections into the bursa. So what you're looking for is the interosseous muscle, and it's a triangular muscle, and the nerve is here. So it's on the plantar aspect. So this is dorsal, this is plantar, and it's coming up towards the transducer. So the first thing we usually see closest to our transducer is the bursa. So can you pick the nerve in this image? It's here. Here's one that's not so good. So we can't see the triangle of the interosseous muscle, and we're starting to see the MTP joint. So this is the level where we want to see the nerve, and you can see that there's shadow over the region of interest. So that's not a great image, and the probe hasn't been moved distal enough. This is your chance now to test yourself. So have a look at the MRI. I'll point out some cystic change. You're seeing a series of patched together videos. So there's low signal now on the MR axial view. And from the dorsal approach, the ultrasound's showing a mass-like structure. This is the dorsal view, so this is proximal, this is distal. This is now a needle being placed into the pseudoneuroma, or into the mass. So you can see that the mass is disbanding. So this tells us it's merely a chronic bursitis and the nerve is being pushed way down here, but normal thickness. All right, before I conclude, I'll leave you with an example of a complication post-surgical. So this is a stump neuroma that is formed years after a neuroma was resected. So this longitudinal dorsal image makes it very difficult to distinguish what's happening. There's a lot of synovial thickening. Who knows what it is? The nerve should be down here. This is proximal, this is distal. But on our plantar view with the Mulder maneuver, we can see more distinction than the MRI perhaps, and the nerve has popped up. It's also displaced sideways over the MTP. So note that once you perform a Mulder maneuver, you may need to then translate the probe left and right to the adjacent MTP just to make sure you're not missing the nerve, because it won't always be in the midline. So we can see a recurrent neuroma through all this muck. So it's just another reason why we don't always want to jump in and do surgery for Morton's neuroma. After the first surgery has been performed, which is usually dorsal, the only option to go in and resect this new neuroma is from the plantar approach, and that can leave a whole lot more scar tissue and create a whole lot more pain for the patient. So before I conclude, I'm going to show you the references. Obviously within this talk we didn't have time to go through, so I'm going the wrong way. We didn't have time to go through the first MTP, and that's simply because it would take me too long to explain the anatomy. But do yourself a favor and grab this reference if you can. It's fantastic to show you the anatomy of the first MTP with its sesamoids and collateral ligaments, and it'll talk through turf toe, which is when you get a disruption through a hyperextension injury. I'll show you one more case and then we're done. So this is sesamoiditis caused by an avascular necrosis under the great toe. So just another thing to look out for if you're seeing fluid within this sort of fat pad, I guess. And that was caused by diabetes in this case. All right, so here's the references. There's 4 pages. I'll just flick through slowly. You can pause the video and copy them down. Thanks for listening, everyone. I hope some of that was helpful. Bye for now.